sort of tools. I think both of them have very clearly said that do we need to diagnose dementia in developing countries if we in Asian countries, but they have made it very clear that looking at the scenario and also made these reference points of the increasing older people, there is a need. Where do we do it? And Shaji has made it very clearly made it that we should not expect them to come to our clinics, but we need to go to them, and it probably in their houses with the help of non-specialized health workers who will also be responsible for other national program. Probably that is one thing, because these are some of the things which both Shaji and Wang have mentioned are totally opposite to 180 degrees opposite to what Ashita has been talking about in the morning, that it needs to be what happens when something is mainly for the research, because Mary also said that there is a high potential for people to be involved in research in these Asian countries. One is that because there is a large population, and the second thing is that they are much more cooperative than people who are in other communities who become highly more rights based and litigious, I think. So it is, if the diagnosis has to be in their houses by non-specialists, some suggestions, and how do we do it with tools, and he has made certain suggestions. I think we need to have specific discussion based on these, how diagnosis should be sort of looked at in the Asian countries, especially the representative countries and the other countries who are not represented here. And I think we need to have some sort of a discussion and consensus on it. Am I correct? And I think people can mainly talk about some of the issues of specific tools, disability, biomarkers, because I think I just want to point out that just as people were talking about the importance of biomarkers, I also yesterday, Chris was talking about how variable the biomarkers can be. Research also showing that there is no, correlation, a positive correlation between the biomarkers and the illness, including the old and unstudied. And we are doing a lot of imaging, and we find that the software which is used and the way the radiologist interprets, unless there is a lot of training, again the interpretations can be very, very different, especially when we are doing functional MRIs, DTIs, and it's all highly can be variable, and people have to have a common language if you have to diagnose them. So biomarkers, when it becomes so internable, then what do we do with the cognitive assessment and disability? So I think these are some of the areas I request people to start discussing.
Can I ask a question? Reminded me, and I think Matthew and Shaji can answer this probably better, that there was an algorithm available which linked together the different instruments that were being used in the single phase N66 study. And some of them were quite easy to use, like the wordless learning task. They don't require an awful lot of time. So I'm just wondering, what is the status of that algorithm, and can we use a limited number of instruments, or can we recommend a limited number of instruments for use in the field-based studies or in primary care, with the algorithm providing the answer? That's one question. The other comment is, I think that we should perhaps agree that we spoke about this yesterday. I don't think we kind of made this an objective, but I think we should make it an objective that we would look at, the continuing discussion after these 2 days should be about standards for primary care in terms of diagnosis, standards for secondary care, and standards for tertiary care, so that we actually structure our thought process according to those 3 settings also, with the Asian context in mind.
Algorithm aims only at coming to a diagnosis based on the information which is derived from a one-stage assessment process by a trained research worker. Beyond that, I don't think algorithm or the sum of all the assessments has any, you cannot translate that into clinical practice. But we have found, meaning people who have used this have found CSID as a very good instrument. Questions, items. Again, I mentioned about EASI. Then there are many things which are feasible in primary care and secondary care. The whole issue about dementia diagnosis is that you suspect, then you have difficulty in confirming. One difficulty is to establish cognitive decline and the presence of an impaired cognitive functioning now. That's a difficulty. This has to be established to make a diagnosis. Second thing is to reliably make a cognitive assessment. Some tests which you can do in primary care, OPD, and then say, okay, there is a problem with cognition. So these instruments may be helpful. So that way CSID brief. And I would strongly recommend that the CSID 10-word learning list is a very good test. It's a culture fair, education fair test. So that is another test which can be easily used, provided you have written down papers of 10-word list. So these are possibilities which do exist. Beyond that, the other issue which we might have to discuss is that why this difficulty. When you use DSM-4, you get a lower prevalence, and then when you use 1066, you get a higher prevalence. And I think the issue there is more with this very restrictive criteria of DSM-4, which insists on very significant social occupational impairment. So I think that's something else.
I think the sensitivity and specificity of the 1066 instrument has been looked at. And I think the 1066, as most of you know, is it comprises of the community screening instrument for dementia, which is the subject and the informant version, which is Hugh Henry's original instrument. The 10-word learning list, which is a CSID list, which Mary adapted to the Indian context, and the geriatric mental state. Now, the geriatric mental state had the lowest in terms of specificity and sensitivity. The highest, as Shaji pointed out, was the 10-word list. And I think that goes in keeping with the episodic memory tasks, which are now being looked at as a kind of marker, as somebody spoke about in the morning. And that is probably the best indicator of even early dementia. Next comes the CSID informant. And so I think, if I remember right, the sensitivity and specificity was right up to about 80% or so, I think, for the 10-word list. I don't remember the exact figures now. So I think, as Krish underlined, if we can sort of discuss around the table as to what one or two instruments we can use for primary care. And I think primary care, as Shaji pointed out, is essentially for screening. I mean, you're going to do only screening. You're not going to make diagnosis. Secondary care in a hospital, maybe neurology, or even I would even say secondary care should even be in a general medicine outpatient, because if you expect people to have specialists like psychiatrists and neurologists, that will really come into the realm of memory clinics or very specialized units. I think that we should have, we should help and educate physicians diagnosing dementia, because that is where they go first. They don't come to us. They don't come to neurologists and psychiatrists. So we need to pick up early, and that's really key. So we should train physicians. I think in the conference a few years ago, which Krish had in Chennai, the ARDSI, there was a whole thing which I think was Japanese Indo-Japanese symposium on how do you train physicians. And I think it's very crucial in our country, at least, to train physicians, because we'll never have enough neurologists and psychiatrists. So I think what we can discuss, what is the one or two simple instruments that can be used for diagnosing dementia by a physician. And of course, third will be the tertiary center. So in the secondary care setting, I think we should have three things. One is diagnosing dementia. What criteria are going to use? Is it ICD, DSM, is it NIA, what is it? And what investigations are you going to do? What minimal investigations? Yeah, so three things there. And of course, in a specialized center like memory clinic, I mean, you can have the whole hog, including PET scan and all that.
I know that you're going to talk later, but I just wanted to check that in the DSM-5 and also in the NIA, just as an importance has been given to the biomarkers. Why is it that people have not? Because people often have been talking about this disability, and then many of the Asian countries having difficulties because the elders are not expected to do anything, and then people just step in. So why criteria like phrases like decline from the previous level of functioning in keeping with the culture? Why those have not been thought about? Because if the culture, Western culture is at the age of 80, you have to drive your car and then make your own, operate a microwave oven. But in a culture like India, you don't do any of these things. Then the cultural aspects come in. So I just want to know, because then that would help us to sort of screen them out.
So let me answer your last question first before I forget, because my memory is starting to decline, or at least my working memory. When we talk about a decline in somebody's functioning, if they were previously driving a car or operating a microwave and now they are not, that inherently takes the cultural, societal, familial, individual performance into account. If you say to me, if you ask about me, can she program a VCR, my children will say she was never able to program a VCR, so this is not a change. So I think that's built in. I think that's, the whole thing is in the context of culture. And for DSM-5 at least, now remember, no one has seen, it's not final yet, it hasn't been seen, but all that's being posted is the criteria on the website as they've evolved, and there's a whole chapter and there's a whole introduction in which all of this is discussed. So I think you may not be as disappointed with it when you see it. But if you are, you don't have to use it. I'm the one who's forced to use it because I'm an American psychiatrist. Anyway, one thing I wanted to say was, I didn't really come to talk about DSM-5, but there is a change, which is that in DSM-4 and all previous editions, there was an insistence that one of the domains that's impaired had to be memory, which is a very Alzheimer's-centric definition of dementia, and this is changing in DSM-5. It's any two domains for major neurocognitive disorder. For major neurocognitive disorder due to Alzheimer's disease, again, memory comes back. Okay? But for vascular, it's not necessarily memory. For FTD, it's not necessarily memory. So I get a little alarmed when I hear, I'm going to just beat up on Matthew again because he's used to my complaint, is that we can't say, shall we use DSM or NIA, because NIA is only for Alzheimer's disease. DSM-5, there is an Alzheimer's component within there, but it could also be for other dementias, and it could be for cognitive impairment due to heart disease, depression, whatever. So, remember that is very broad. And I think one of the results of these new criteria is going to be that the prevalence will appear to go up because we are including impairment in other domains, and prevalence will appear to go up if you include the mild neurocognitive or MCI stage. Both of those will appear to inflate the numbers. So I don't think it's so much a matter of which tests do you use as what are you trying to accomplish and what are the essential constructs or domains that you're trying to tap. And if we say we want to study memory, then say, there's visual memory, there's verbal memory, there's this, that, and the other. Anything that taps those things is acceptable. Or we want one visual and one verbal. And then let it be a story or let it be a word list, depending on the situation and the kind of population you have, and make some attempt to standardize those so that everyone is drawing from the same pool. But if you say everybody has to do the same test, there may be reasons it's not possible. And so if you find the picture memory test, and there are a couple of different picture memory tests and so on, if you find it's performing as well as the word list in your hands, then it should be okay to use that, and it should be okay to have something that has, good sensitivity and specificity in your population. I would not worry so much about predictive value, because predictive value depends on the prevalence. If you're in a memory clinic with a lot of people with dementia in it, with Alzheimer's in it, then you're going to have high predictive value, positive. And if you're in the community or the population or general practice, it's going to be lower. That just depends on how many people there are there, but you want to focus on sensitivity and specificity. sorry, you had one more point. No, I've already forgotten.
No, I was just saying that why is it, because you're saying culture, but I think though it talks about IADL, but IADL in different cultures, that's why I'm saying the broader term of why culture is not used, because then it could be cutting across various types of population.
But I'm sorry, I'm not following, because if the criterion says there's been a decline in the individual's functioning, then it means whatever that individual was doing before, he's not able to do now. So whether it's harvesting or whether it's using, so why doesn't that take culture into account automatically? No, but I mean, why does that definition not seem to include culture? Because it's not based on what is everyone in your culture doing, it's based on what you were doing before. Right?
The only reason is that some of the elders are expected to do nothing.
Right.
So when we say that, and then definitely there it goes on to much more only onto ADL rather than IADL at all. Because
so what we found when we developed the EASY was exactly that there's very little that people are expected to do, and there's differences between what men and women are expected to do. And if you say, well, if he had to do it, could he do it? They would say, well, he doesn't have to do it. So this was why we came up with questions that were not so much about carrying out tasks as, can you give him a message and will he give it to his wife, or can you, things that seemed, and as I said, we started with 60 items and we reduced them to 35 and eventually reduced them to 11 or 12 based on the frequency with which the items were being endorsed and whether it was correlating with the Hindi mental state exam score. So we were trying to pick up those things. But you're right, if somebody is not expected to do anything, then you can only try to judge, does the family trust him to carry a message, or does the family, and that is the problem with the IADLs. That is exactly why people are relying more on objective cognitive tests, because at least it's uniform once you've standardized it. You can't say that in Bangalore and in Chennai and in, Balabgarh, just because it's India, that everybody has the same IADL. So it will be very hard to come up with a scale of specific items. Now there's, in the CDR interview, if you do that CDR thing online, you see how they ask what this person was doing before and whether that person was still doing it. So you have to spend some time finding out, compared to a year ago, what is she not able to do now? It's not like on their 60th, or maybe on the 60th birthday, they say you don't have to cook anymore. But, if there's some gradual change or dramatic change in something, it does require taking a history. You can't come up with 6 items and say they will apply everywhere. I don't think it's possible to come up with a scale with, universal items for instrumental or higher order. You can for basic, self-care, hygiene, that kind of thing. I don't think there's an answer to that question.
I was going to say the other thing, of course, is that when I say that Singapore is resource constrained, I'm not kidding, because just because you have a high GDP doesn't necessarily mean that you have a lot of resources. And one of the key resources that we don't have is actually trained people, or at least people willing to be trained to do this kind of assessments. So the feedback we get from our GPs and from primary healthcare is that life is already horrible enough seeing 50 to 100 patients a day without having somebody tell you to do a 7-minute screen or a 3-minute interview or whatever. So we've gone through many iterations with our colleagues saying, what about this score, the mini GP cog and so on. And the answer is no, until we got to the 88, which is administered by a caregiver or the informant. And that was tremendously popular because the GPs didn't have to do anything except see the result and consider whether it was worth worried being concerned about. The other thing that we also have confirmed is this issue of who should be taking the test for informant-based studies. And I think we've confirmed what other people have shown, that for something like the ADA or other tests, the caregiver-based assessment is much more reliable for 2 reasons. If you're demented, you tend to say that there's nothing wrong. If you are anxious and worried, well, you tend to say there's lots of things wrong. And so a reliable informant is much more reliable. And finally, there's the issue of, can a screening test like this actually pick up not just dementia, which of course is highly desirable, but as Asita has said is an end stage problem, is do we have any reliable test to pick up early dementia? Let's not call it MCI, but early stages where you think you can intervene. And I think there is emerging evidence that scales like the 88 can pick up CDR 0.5 at least, or MCI, but a lot more, it needs to be validated in other countries as well. So in summary, I think that if we're going to recommend anything, please make it simple. Please validate it in your own country. Do not accept other people's cutoff points.
Yeah.
Silence.
Can something like colon drawing be used as a substitute for block drawing test?
I'm sure many people, Swarna Aladi is one person who constantly talks about it. But the problem is, how do you test men then? Because women are the only people who draw colon, especially in rural areas. But if you're going to have a tube, then it has to be exclusively rural, because I'm sure I do not know how to draw a colon, despite being a South Indian woman.
I don't think you want it to be an overlearned ability. I don't think you want them to draw anything anyways, right?
The dementia is always vulnerabilities. Who is being not able to control is definitely not a normal thing.
That is correct, but then it's not doing the same thing as clock.
Yeah.
Trying to get either visual spatial or identity control. You're not going to get that from a memory test.
And even it may not be an early stage, that's another problem. Apart from you are testing something different, I think that we have to take this decision that paper and pencil test to sort of perform in public in front of another person who is testing you is probably not a good idea to test older people in Asian countries who are predominantly illiterate or had not had formal education and had never been asked to do tasks like this. Give a paper and pencil and then draw. So I think, and this is proven to be not fair. It's not education fair test. So even clock drawing test is not an education fair test because people are very anxious or not used to perform well in public domain. There is problem, education bias is there. So that is not a good test. So anything which would not require a paper and pencil test, which is much more, which wouldn't require any other equipment, that is easier. Yeah. Those are possible alternatives to test this.
I don't know. I mean, the MOCA with some adaptations perhaps to some extent fits the bill in many ways for cognitive tests. And I don't think we should be reinventing the wheel, but I think if we say list of tests that can be adapted in the Asian environment depending on the convenience of the, so if we're putting a list, then I would say that we should think about which are the tests we would put in that list. Tests, of, yes. And then we would also obviously put into that list something that tests activities of daily living and functional ability. And we would put into that list something that tests